So if you have a great VO2 max, means everything along the chain is working well. So it's a fantastic tool to really assess your overall cardiorespiratory fitness.
If you see us producing more YouTube videos, it's because we hire editors, and that's made possible by the revenue from our lab's testing services. This includes something we are increasingly known for, strength testing, but also other tests like VO2 max tests and testing for muscle oxygenation levels. Some of these clients go on to do personal training with us, and we learn from the domain specialists that we feature on this channel how we can provide even better training and testing services to them. In a way, it is a continuous loop of learning, improvement, and better service. This has even progressed to a stage whereby we are running courses for fellow physios and trainers approved by the relevant regulatory bodies with, for example, Dr. Danny Lam, and in the future, other guests as well. If you'd like to see more content, receive better services, and enjoy them at a grandfathered rate, please feel free to reach out to us today to see how we can help you with a healthy aging journey. With that, back to the episode. Hi, Dr. Koh. Welcome to the show.
Hey, hi Jing Zhi. Great to be here. Thanks for inviting me.
No worries. Thank you for being here. I think we got to know each other through LinkedIn.
Yeah.
After that, we met for coffee, and I invited you for one of the events on VO2 Max, and then you came down to do a VO2 Max yourself.
Yep.
And so we're going to start there. When patients ask you, how do you explain to them you're referring to VO2 Max test?
So I give two imageries. The first one is I ask them, how do you assess your stamina? Then they'll tell me, oh, I go by my timing when I run this and that, or my swim time, or my cycle time. I say, no, these are surrogates. These are not true reflection of your actual cardiorespiratory fitness. And with that in mind, then I ask them, have you watched Top Gun Maverick? And they, oh, yeah, I watched Top Gun Maverick. I said, do you remember Tom Cruise running with this special mask in one of the scenes? Most would, because he was topless, right? Yeah, so that gets the conversation started, and then I deep dive more into what this test entails and what it actually does to assess the entire spectrum of your full cardiorespiratory fitness.
And what's that detailed explanation like, if you don't mind sharing?
So we always talk about VO2 max, right? So VO2 max is the end point in this assessment. But of course, along the way, when you do the test, there are actually other parameters that pop up. But these are more technical, and they tell us different aspects. By the end of the day, the VO2 max is a real reflection of your fitness, your cardiac fitness, cardiac lung fitness. And I can just add on and on. Why do I say that? Because to measure this, essentially, this is the efficiency of your body in taking up oxygen from your circulation, how effective it uses the fuel, which is oxygen. And how does this work? Imagine the journey of an oxygen molecule from the atmosphere, going into your nostril, passing through the lungs, going through the membranes in the lungs, then into the capillaries, carried by the red blood cells, transported to the various organs, and which is the largest organ that uptakes your oxygen metabolism? Your muscles, right? So it ends there. Then the muscle uptakes it, uses it, and then converts it to lactate carbon dioxide, your Krebs cycle and whatnot. And then it returns the used up red blood cells to your lungs, and the whole cycle starts again. So this whole journey involves having a lung that works well. You don't have a diseased lung. You're not having a smoker's lung where there's a lot of scarring, or touch wood, you have cancer or whatnot, and it's affecting lung ventilation, perfusion, and the mismatching, right? You need a good red blood cell, right? If you're anemic, if you're a certain type of what we call hemoglobinopathies, where the hemoglobin that carries the oxygen is dysfunctional, then you run into problems. So you have patients who have, say, serious menses problem. They lose a lot of blood monthly, so they are anemic. Not through any fault of theirs, but through a physiologic cycle. And they find that the stamina is just not keeping up. You check their VO2 max is abnormal, but are they unfit muscle-wise, heart-wise, lung-wise? No, they're not. It's the oxygen carrying capacity that is abnormal. So after that, the red blood cells, after they take up the oxygen, where do they go? How do they get there? It's via the pump. And what pump is it? It's our heart. So if you have a weak heart, you have a heart that is stiff, that cannot fill properly, you got problems, right? You can't deliver the oxygen efficiently to the end organs, which are the muscles. But remember, if you have muscular disease, so in certain subsets of patients, they have muscular dystrophy or they have abnormal muscle development, right? These muscles are ineffective in extracting oxygen from the red blood cell. So your upper stream of the journey may be normal, but the final recipient is dysfunctional, and you also have an abnormal VO2 max. So if you imagine this entire journey, you realize the VO2 max actually represents the whole spectrum of this sequence of events. So if you have a great VO2 max, means everything along the chain is working well. So it's a fantastic tool to really assess your overall cardiorespiratory fitness.
But at the same time, and as a practitioner who runs the test myself, one of the things we do in our process is we tell whoever comes in, you might want to check with your doctor if you are fit to do this test or you are ready to do this test.
Right.
And when that happens, if they go to you, what would you do? Right? Is it safe for everyone?
By and large, if you don't have any underlying conditions, whether known or unknown, that may be aggravated by a strenuous episode of exertion, then by and large, you're safe to do the test. Because the test involves either cycling, running, or swimming, right? Most people do it on the treadmill machine where they run. And we have to run you hard. Because if we don't do it to the full limit of your capacity or capability, then we are shortchanging you, right? We are not measuring your true VO2 max. So we have to push you. But in order to push you, we need to know whether you're well enough to get pushed. Last thing we want is we push you and, something negative happens.
We now move on to not just testing people for their VO2 max, but another topic which contributes to heart disease, hypertension. Well, from what I found, according to National Population Health Survey 2022, one in 3 Singaporeans aged 18 to 74 has hypertension. But if we look at the survey's numbers, 8% of Singaporeans between 18 and 29 years old have hypertension, and this number rises significantly to almost 77% among those 70 years old and above. So my question is this hypertension something that is inevitable as you age?
So in common speak, hypertension is high blood pressure.
Yeah.
Our pressure will fluctuate across day to day, week to week, year to year, based on the kind of activities we lead and the kind of body conditions we have. Now, hypertension basically means on a long-standing basis, your blood pressure is constantly elevated. And by definition, the cutoff is 140 over 90, right? So there are two numbers. When you measure your own blood pressure, be it with one of those off-the-counter blood pressure machines or in the clinic with a doctor in the hospital, whichever setting that may be, those two numbers are constant. So 140 over 90 are the so-called definition above which you have hypertension. Now, there is precondition whereby your blood pressure is not reaching the stage of hypertension, but you are getting there. That means you're no longer in what we call normal tension. So that is in the range of 130 to 139 systolic, which is the top number, and 80 to 89, which is diastolic, the bottom number. A lot of these numbers from the surveys and whatever population studies are based on clinic numbers, right? Meaning to say these are documented blood pressure measurements from a healthcare setting. We have not even included numbers where patients are measuring it themselves, but they are not reporting it to their healthcare providers and hence going into the national system. So we are missing a segment. Long answer, but in short, yes, hypertension will exist in various forms and formats in whatever setting. And in general, as we age, there is a higher prevalence and a higher predisposition to develop. So it doesn't mean that if you are 40 years old, you have no high blood pressure right now. It doesn't mean in 10 years, 20 years time, you won't develop. So there are many risk factors, right? And there are well-known risk factors like being sedentary, being overweight, having a high salt diet, insufficient exercise, insufficient rest, high stress, be it domestic stress, work stress, all kinds of stress, mental stress. And then the list goes on and on. So it's not all or none phenomenon. The pressure itself is a range, is a spectrum, is a continuous variable. And the factors that contribute to it is also, multifactorial. It's not one factor that causes it.
Many factors, and we can't really pinpoint to say this is the factor causing more people to have hypertension when they age.
There's no one factor.
Yeah,
You're right. So it's multiple factors. Yeah, and if you go into the Health Promotion Board website, they will list you down at least 10, 20, 30 different factors.
And so if we start early and we try to keep our blood pressure in the healthy range, which I believe is 120/80.
Yep.
Does that mean that we have less likely chance of getting hypertension when we are, let's say, 70? versus someone who does not care about their blood pressure until like they are 50? Would they have higher chance of getting hypertension when they're 70?
So there are two parts to this question. First part is if they take care of themselves when they're younger, would they develop hypertension? And the second part is if they already have some form of mild hypertension and they take care of it, would it worsen or would it get better? So let's answer the first part first. If you're well, no hypertension, but you don't go and monitor it, you don't go and check it, in time to come, are you at higher risk? Certainly. You can only solve a problem that you know exists. If you don't even check, then you're not preventing things from happening, right? So prevention is better than cure. You want to not even want it to develop. So again, if you look at the whole list of contributing factors, there's many things you can do, right? Taking care of your sleep hygiene, making sure your stress is well managed, making sure your intake of salt is not too excessive, making sure you're getting sufficient amounts of exercise. Certain things we can't change. For example, age we can't change. For example, family history we can't change. If both my parents have high blood pressure, then I have a higher chance to get high blood pressure. It is a polygenic inheritance. When I say polygenic inheritance, that means it's not a single gene that is defective. It's multiple genes coming together, right? So if both parents already have, inverted commas, defective inferior genes, then I will inherit it. Then I am at risk. So if I don't take care of all the other modifiable risk factors, my risk is even higher. So that's part one of the question. So part two is, if I now know, let's say I go and buy whatever brand of blood pressure machine and I check at home, oh, it's constantly, 135 over 85, whether I'm at rest, whether, I'm active or not, then you are at the pre-hypertension stage. But if you ignore it and you don't change your lifestyle, you don't change your diet, you don't do things to intervene early upstream, then chances are it will get worse. All right? There's no reason for it to get better if you do nothing about it.
Does it get harder to change when you get older?
Certainly. So it's like a fixed deposit account. If you deposit early, you get a compounding effect. Same thing. As we age, our arteries age as well. They stiffen up. So if you are accelerating this stiffening process via poorly controlled blood pressure, then when you want to start medications later on in life, because finally you decide to do something about it, it is a bit late in the game. Then it gets harder. You may need multiple drugs to control it. So why allow that to happen when it can happen upstream and earlier? So perhaps if I reframe your question, it will be, if I have elevated blood pressure, and I think I have done as much as I could in terms of lifestyle and diet, should I then consider medications for blood pressure? And the simple answer is yes, because you want to control it upstream. And the next question commonly thrown at me will be, Doc, so after I control it, can I stop it? And my answer is always yes and no, because it depends on the control, right? And it depends on the dose of the medication. Oftentimes, if it's well controlled, we can start to tail down. But we continue to monitor, right? Because there are times where you cut down and then there's a rebound and you really need to put it back on, right? And then there are times where your lifestyle and your whole environment, you really change it such that even if I tail off the medication, your blood pressure still remains nice. Then we can consider taking it off. So just because we start a person on medication doesn't mean they are dependent on it for life, right? I think that's the common misconception and fear amongst people when it comes to starting medication. Like, oh, I will be dependent on it forever. Not true.
On that note, hypertension is more common among men, am I right?
Mm-hmm.
But if we look at heart disease as a killer, which is something that hypertension may lead to, the stats show that heart disease is the #1 women killer in Singapore. Are there any gender-specific reasons as well as this slight, if we can compare those two quite different things, disparity in the context?
If we want to deep dive into it, there are social determinants and there are biological determinants. So in general, in modern society, women tend to be more loaded with a lot of other things that they need to attend to, including caring for the family. And a lot of times their health takes a back seat. So their health-seeking behavior is not as active as that of men. So remember our earlier conversation where we said if you disregard or you don't monitor your health, and by the time it gets into trouble, then it's a bit late in the game. So that happens more often in women than in men because of all these social reasons. Now, the second thing is women have a different biological profile compared to men. They undergo pregnancy. They have changes in their hormonal profile as they undergo menopause and what we call the perimenopausal period, but there's fluctuations in their estrogen and progesterone, and those have an effect on blood pressure as well. Even pregnancy, in certain types of high-risk pregnancy, advanced maternal age, those predispose these women to high blood pressure later on in life. There's a condition called preeclampsia, where they get high blood pressure during pregnancy, and after delivery, it settles. But having preeclampsia in itself, even after it resolves post-delivery, in the future, they are also at risk of developing de novo high blood pressure.
Does it mean that for women who come into your clinic, you advise them to check their blood pressure even more so than men?
I advise everyone to check blood pressure regardless of gender.
And at what age do you get people to start checking their blood pressure?
That's a good one. Most young people, they assume, they are invincible. They don't need to check their health. But it's not true. Simple question, but complex and loaded answer. So there is essential hypertension, or what we call primary hypertension, where really there is nothing that's specific that is driving the high blood pressure. It's the garden variety. Everyone gets it after a certain age, that kind of thing. So this is the polygenic, genetically determined and lifestyle determined type of high blood pressure. Then there is secondary hypertension, whereby there are specific conditions like thyroidal disease, like adrenal gland disease, like kidney disease, like sleep apnea. There are specific underlying conditions that actually trigger the development of hypertension if the underlying condition is not treated. So in those, if you are a young hypertension patient, meaning to say they come into my clinic, you say, my blood pressure has been running at 140/90 the last few months and I'm only 28 years old. I have a stronger tendency to go and check for these secondary conditions to make sure it is not something else that is happening that is driving this high blood pressure. Because it is uncommon for young people to develop hypertension. Not impossible, but not uncommon.
So there's no particular age which you say, yeah, you should start checking.
If you remember your pre-enlistment days at 18 years old at CMPB, did they check your blood pressure?
Wow, that's quite a while ago. I have no idea.
Yeah, they did. Yeah, so everyone should get a check. Even, pediatric patients going for their consultation for whatever things in the pediatric clinic, routinely, they should get a check, just to be sure.
And how often do you recommend people check their blood pressure? I was checking my blood pressure almost on a daily basis. Right, up to it went down to below 120, below 80. But after that, I just stopped completely. What is the recommendation though?
How long does it take for you to measure one cycle of blood pressure?
Wow, less than a minute.
Less than a minute. Why not do it daily?
It's a good question, but I did find myself needing to adhere to the timing, right?
Yeah.
Things like that, which put a little bit of pressure in my life.
Yeah. There's no wrong or right answer to this. The more you monitor, the more data sets you get, and the more you know on a day-to-day basis how it fluctuates.
Is there a healthy routine around it?
Yeah, I would say minimally check it once or twice a week.
Okay.
Yeah, minimally. If you're hardworking, do it daily.
Moving on from hypertension, I went to the web to find out what are some of the commonly asked questions around heart conditions.
Right.
So a few technical terms pop up. One is coronary artery calcium score, CACS. The other one is PCSK9 inhibitors. And then you have statins. Tell us your thoughts on all three terms.
Let's start with the easiest, statins. Statins is commonly known as the cholesterol medication, right? That is given for patients with high cholesterol or previous cardiac or brain events like a stroke or a heart attack. So statins bring down your bad cholesterol, the LDL, what we call the low density lipoprotein, which drives a lot of bad events from happening.
How does it work? Are there some common complications?
Okay.
Right.
Yeah, good questions. So they work at the liver. They belong to a class of medication called HMG-CoA reductase inhibitors, which metabolizes the bad cholesterol in the liver, and they improve this metabolism of LDL in the liver, and hence increase LDL clearance from your body. End of the day, the KPI, right, is to reduce the LDL, and statins have a big role in that. In fact, it's one of the mainstay of medical therapy when it comes to high cholesterol. What are the potential side effects? So the common ones include things like big muscle group aches. So big muscle groups including the shoulders, the lower back, the glutes, the calves, and so on. Not common, but when it does happen, again, most of the patients that take statins will develop some form of tolerance or resolution of these symptoms after a while. Could be a few weeks, could be a few months, right? Some get persistent and very troubling side effects, and we switch them around. Either we switch them to a different form of statins, and there are many forms of statins, and we can go into the details like, is this a lipophilic or is this a hydrophilic statin? Basically, the biochemistry of the statins. Different types of statins have different side effects profile. Some may benefit patients more than others in terms of the side effect tolerance. And then the more worrisome side effect is, which is rare, less than 1 in 1,000 cases, is severe breakdown of muscles. So we call this rhabdomyolysis. Sometimes you see this after very, very strenuous exercise, like someone who went for intense bout of a marathon or triathlon, and then there's this massive muscle breakdown. And the other rare side effect, again, extremely rare, less than 1 in 1,000, is extreme liver inflammation, right? So hepatitis, but drug-induced hepatitis, very rare. Why some improve significantly on statins and why some don't. So lifestyle and diet plays a big part, right? Just because I start you on statins doesn't mean it's a license to kill and now I can eat all kinds of unhealthy but yummy food, which is, again, a big problem in Singapore because we are surrounded by yummy food. Multifactorial. So if assuming you have done all you can to optimize your lifestyle and diet, and the cholesterol is hardly budging, that means intrinsically your body is just not clearing it fast enough despite that statin dose. Then we have to escalate the dose. So it's not so much the failure of the statin, but rather we are not optimizing it yet.
What about other two technical terms?
Calcium score. So calcium score, or what we call CT coronary calcium, is a quick and easy assessment of our coronary arteries of the heart in terms of how much cholesterol deposits there are. It is a non-invasive, low-dose CT scan where you don't need an injection. It's in and out. It's almost as fast as doing a chest X-ray. Radiation is also in the range of a few chest X-rays worth of radiation only. What they want to see, or rather what I don't want to see, are specks of calcium depositing in the arteries of the heart. Why? Because when there are cholesterol deposits in those arteries, they come together with calcium. So the higher your calcium score, it tells me there's a high cholesterol burden inside the arteries of the heart. This is also a predictor of your 5 to 10 year future risk of a cardiac event. The higher your calcium score, the higher that risk. What's the best score? 0.
So should people be finding out their scores?
Again, it depends on your risk profile. If a 20-year-old walks in and tells me, I want a calcium score, I say no, right? So minimum. It takes time for calcium and cholesterol plaques to build up also. So if you're of a relatively young age, below the age of 40, the data is calcium score is not very useful in risk prediction for you. If you're diabetic, you're in your 50s, you smoke, your father had a heart attack at 58 years old, you are overweight, and now you're thinking of statins, but not so sure, I'll say do a calcium score. If the calcium score is not normal, would you take a statin? I'll push strongly for it.
I think those are great general knowledge to have around calcium score. And the last one, PCSK9 inhibitors.
It's again long-term, but basically it is a form of new cholesterol medication that dramatically lowers LDL much more than statins. But it is an injectable. Once every 2 weeks to 3 weeks. It is not cheap. And it is not meant for everyone. It's usually reserved for the highest risk patients, those with either stenting or stroke, or had gone for a coronary artery bypass surgery, or had a recent heart attack. We want to lower the cholesterol very, very low.
So it's one of those things that if you want to find out more, you should just talk to the doctor.
Yeah, it's a deep topic.
Cool. Now, moving back to the exercising and the healthy lifestyle modifications, one of the marathon race participants passed away after the race. And if we look back across the Standard Chartered marathon history, in fact, there were 2 other cases, and those people have heart conditions. In 2016, this 28-year-old British national was found to have suffered sudden cardiac death on the onset of arrhythmia. And in 2011, a 22-year-old, after running a half marathon, was found to have been suffering from a heart condition and died of acute coronary insufficiency. So when participating in a marathon, how important is it to get a doctor's clearance? And at what age does that matter? Because it seems like these people are pretty young.
So good question, and it's something that really is at the back of everyone's mind after a certain age, and they decide, okay, I think I want to run a half marathon, a marathon this year or next year. And I want to push myself during training. I want to push myself to get the PB during the actual run. And then they read news like that, and then they, wow, okay. So let's talk about the commonest cardiac causes of collapses during exercise events such as this. So top 3, in the younger age group, not so much the older. Older, usually it is due to acute heart attack. Yeah, because they have plaque build-up in the arteries really, and then that spike in activity during the competition really tips them over, right? So the older people one is heart attack most of the time. Then we focus on the younger one, right? I'm only 40, considered quite young, right? Should I be worried? Should I get screened? And what are the guidelines? So there are different societal guidelines across different parts of the world. Asia Pacific, we have our own. I was part of the working group that worked with the cardiologists around the region to come up with who needs an ECG at what age group, doing what kind of exercise. So basically, it comes down to these few things. Number 1, when you train, when you exercise, do you have symptoms or not? Do you have exertional chest pain? Do you have very unusual exertional breathlessness? If you have that, please go and get checked. Number 2, your age. So what is the magic number to move this age needle? Is it 30? Is it 40? It depends. It depends on the kind of activity you're planning to embark in. Like, let's say if you are going to take part in an international chess competition, right? The cardio stress is not very high, right? So is there a need to do cardiac screening? No, not really. But if you tell me I'm going to take part in the Langkawi triathlon in 6 months' time, I'm going to push myself, I haven't trained for it for a few years, should I be worried? You know, my parents, they have high blood pressure, nothing much. Should I be worried? I would say do a screen, do a check, because you are going to push yourself really, really hard for those few hours. And you are going to train hard for the next few months as well. The last thing you want is you overtrain, not say overtrain, but you push yourself to a certain limit and something gets triggered and happens, right? So coming back to a younger age group where we want to know what are the common cardiac problems that really trigger such sudden cardiac events. Number 1 is this condition called hypertrophic cardiomyopathy, which is abnormal heart muscle thickening. It is genetically inherited. Sometimes they have no symptoms until a bad event happens. But it can be screened. It can be screened. So if you have a family history of sudden cardiac death in any first-degree family members, get checked for that, right? Sometimes ECG, the electrocardiogram, can detect certain patterns that suggest this, but it's not always sensitive. So someone with this condition may have a normal ECG. The only thing that can really pick it up is cardiac imaging, either with the ultrasound or with the MRI. Second is coronary artery structural issues, what we call coronary artery anomalies, where the arteries of the heart courses through an abnormal path. And certain variants of that, these arteries course between the big trunks of arteries. And during intense exercise, these trunks can compress on the coronary artery and cause sudden cardiac arrest. Again, very hard to screen. If you have exercise-related fainting, like in the middle of a run, you suddenly faint, or in the middle of the run, you're a young man, you get constant chest pain, which only gets relieved by stopping the run, get a check. Yeah, very, very hard to screen with ECG. ECG is invariably normal in this kind of cases. And the last one is what you mentioned earlier about one of the participants, right? Arrhythmias. Arrhythmias basically mean abnormal heart rhythm. Now remember, our heart is not just a pump, but also it has an electrical function. And that's how we capture the ECG signals. In some conditions, very bad and unstable heart rhythms can develop during peak exercise or peak stress. Yeah, again, a resting ECG when you're not doing anything, just lying there doing the ECG may not pick it up. Yeah, so these are the things that are discovered as the top 3 causes of young sudden cardiac death in athletes. So if you do have a family history, if you do have symptoms, no matter your age, I will request you to get it checked first.
Very insightful. Apart from these, what are your general workout and healthy lifestyle and healthy diet, healthy sleep recommendations? I know many doctors give the very simple advice of eat, sleep, and exercise for your health. Do you have something more detailed that you follow yourself, for example?
Okay. The American Heart Association makes things easy for everyone. They call it Life's Essential 8. This is to safeguard your heart health, right? Reduce risk of future heart attacks or future progression of heart failure. So what are the Life's Essential 8? Number 1, diet. Yeah, I'm going to say the same thing. Number 2, exercise. Number 3, sleep. Number 4, take care of your weight. Number 5, take care of your blood pressure, sugar level, cholesterol. And the last one, don't smoke. So these are the 8 things. You take care of these, your body will take care of you.
With that, we've come to the end of this episode. Thank you again for being here.
No worries.
If you guys have any questions, please feel free to put them in the comment section below. If not, till next time, take care.